interesting. You mentioned patient-centered, and I don't know if you're familiar with some work early here in London, Ontario. Dr. Ian McWhinney, we consider our founder of family medicine here in Canada in many ways, in modern family medicine. But he spoke of the reasons patients come to their physician, right? The limit of anxiety. They're worried so much about their symptom.
Yeah.
The limit of tolerance. They can't stand the pain or the itch or whatever. The ticket in. They want to come in for some other reason. They say it's their cold, but they really want to talk about the troubles at home or their administrative duties. I need a form, I need a sick note, I need whatever. And so we're very interested in seeing how this will now apply, as telemedicine evolves. Are we still able to address those needs with our patients? And I think, one of the myths being just that, well, it's by telephone, the patient doesn't really care when I call, it's keeping on time, for example, would be a very simple patient-centric means of addressing their need, because they're at home and you tell them you're going to call 11 o'clock and you call it 12. And I've had days I've gotten behind, there's a message with the secretary, are you calling Jim? He's waiting, right? I was like, oh, I'm sorry, I'm so far behind. So it's interesting, right, to see how still, as I've said, and you've said, patient-centered care is best care. And the history here within Canada is interesting. Quickly, just a comment about that. Dr. Maxwell House, who was a neurologist and started telemedicine supporting patients, neurology problems, supporting patients in remote rural areas, and actually founded a program at Memorial University. And we here in Canada had the first trained physician in the world with a fellowship in telemedicine. And Dr. Rod Alford, who is recently, I think he's in Calgary practicing primary care. So there's quite a history here in Canada. That program is no more, interestingly. And I find that fascinating because we really have no, certainly within Canada, dedicated education for telemedicine. It's kind of ad hoc or it's incorporated into, the training, but not specific. And I'd be interested in hearing your comments because it looks like, there is definitely a defined need for physicians to have greater training. And what do you see as maybe some of the myths and some of the needs around that going forward?
Yeah, I think training must be, it must be developed. First of all, it must be conducted. It must be adapted to the new means that we have now, to the new digital tools. I really love all these new digital tools you can use, like digital stethoscopes, apps, labs at homes, everything, it's like a whole new world that has reopened for medical students now who have to learn this, to adjust it, to use it. And it also comes back to the point of patient centricity, and also to the way how doctors have to organize their offices or to reorganize their routine. Because what we will see, I strongly believe that we will see hybrid models there. You can visit your patients face to face or see patients face to face. And of course, you cannot administer vaccine over video, but you would like to come them in and to chat with them and to have this strong relationship. But sometimes you just check on blood pressure or data or blood sugar data, and then it's enough to call and to see, or they send you data via PDF or via email or however, or messenger, I don't know. But it's like adjusting also your whole office, your routine, like saying, this is my dedicated digital office space. There I have visits visits like from 1 to 3, and in that time I can see only 6 patients or whatever. You have to adjust it because we design our inpatient offices to our routine, but now we have to design our digital offices as well, and to figure out how much time do I need, what is the procedure, do I need a patient kiosk, do I need this, how do I deal with healthcare insurance, with the forms, with history, and so on.
Yeah, it's interesting. I mean, you just touched on the myth, right? The myth being that it will not adopt my workflow. It takes a little bit of work, I think, to adopt. But I have found, for example, and the bulk of my encounters still being telephone right now, while I'm chatting, I can have a screen open and I can be dropping into their email by secure messaging. It's in within the EMR, maybe a web link to a specific condition we've talked about, or maybe educational materials that I already have preloaded. And I actually found that it's almost easier. It's improved, honestly, I would say improved my encounters, because before, what would I have to do? Go out, grab the paper out of the tray to get, a diabetic sheet or an educational material. I think there's still some issues of equity, and those patients that maybe is still many that don't have access, right, to the internet or computer, and we're
Mm,
still problem solving around it. But yeah, it really does. I think that is a myth that it doesn't adapt to the workflow. You're right. It takes a
yeah.
little extra effort, but it does. Yeah.
Yeah, the myth is that you just log on and then you continue like well, the same way as you perform face-to-face visits, but it's not true because you have to deal with so many other issues like patient's privacy, internet access, device access, and so on.